Hello, my name is Victoria. Welcome to another study session. Today we will be studying the pancreas and specifically pancreatitis. So get your jotters and let's stay motivated and study for our Nclex. Pancreatitis is an inflammation of the pancreas. It can be acute or chronic. Let's remember that the pancreas is an endocrine and exocrine gland. And as an exocrine gland, it produces enzymes that empty through ducts into the small intestine. And then, as an endocrine gland, it releases hormones that will be secreted into the bloodstream directly. So the hormones are like poured out into the bloodstream. While its exocrine function, it gives out enzymes that will have to pass through ducts, and from the ducts it will pour its contents into the small intestine. Diseases of the exocrine pancreas affects the secretion of digestive enzymes, because we have already established the fact that digestive enzymes are going to be produced by the pancreas and released through ducts and emptied into the small intestine. So, when we have acute pancreatitis, it usually develops in middle life. And then gallstones, alcoholism are the primary risk factors for acute pancreatitis. So when someone has gallstones, like we talked about when we reviewed cholecystitis, if you've not watched the video we did on cholecystitis, you can go back and review it. It will be helpful. Then alcoholism is also the primary risk factor for developing chronic pancreatitis. And it is a disease that eventually leads to destruction of the pancreas and finally pancreatic insufficiency. So these patients that have pancreatitis, when we look at them, they are looking ill, acutely ill, and then they may have to be on lifelong treatments. Let's go to the pathophysiology. So acute pancreatitis happens when the pancreas itself is damaged or its duct leading to the duodenum is blocked. So either there is a trauma that causes a disease or a destruction to the pancreas itself, or that passage duct through which it empties its contents to the intestine is now obstructed. There is something there that is blocking it. Pancreatic duct obstruction by a gallstone or spasm of the sphincter of Oddi, which is associated with alcohol use, can obstruct the outflow of pancreatic enzyme. So let me check. I jotted down some points too about it, and since it has been mentioned, let me talk about it. The sphincter of Oddi. When bile is released from the gallbladder, it will pass through the cystic duct and then go down to the common bile duct. Then it will open into the duodenum with the help of should we call it a door? Let's call it a door. So that door is the sphincter of Oddi. So the sphincter of Oddi is a door that will either let the bile to flow into the duodenum, or it will lock it and the juice will not flow. So when the sphincter of Oddi contracts, then juice can flow. It will lock, like it locks itself, so the juice will not go. And then when it relaxes, it kind of opens and allows for that flow. So I just wanted to talk about that sphincter of Oddi, how it opens and closes to allow the bile juice to be poured into the duodenum through the ampulla of Vater. All right, let's continue. So we were just trying to talk about things that obstruct the outflow of pancreatic enzyme. So when there's an obstruction, a self-destructive process known as autodigestion will begin. So because now the pancreas cannot empty its content, it cannot release its contents through the sphincter of Oddi into the duodenum via the ampulla of Vater, that pancreatic juices will now start accumulating in that part of the pancreas and result in autodigestion, begins to destroy its own pancreas. Please, we are trying to understand, so let's work together so we get these concepts right. The milder form of acute pancreatitis, interstitial edematous pancreatitis, the pancreas becomes inflamed and edematous. It becomes inflamed and edematous. This process is self-limiting and clients recover completely. So we are talking about the less destructive one, because this one we have talked about now, there is autodigestion of the pancreas. The enzyme begins to eat up the pancreas. But now we said that when the patient has the mild form, the simple form of pancreatitis, what just happens is that the pancreas tissues, the tissue or the parenchyma within the pancreas begins to swell. There is interstitial edema. So in that edematous state, it can resolve on its own, and the patient can actually heal and feel better after this whole process. So now this interstitial edematous pancreatitis is a mild form of the acute pancreatitis. Okay? So now they are trying to tell us that the acute pancreatitis has two types. It still has the mild form and it has a severe form. We are learning. So the interstitial edematous pancreatitis, which is self-limiting and can resolve on its own, that one is the mild form. The severe one of this acute pancreatitis is what we call the necrotizing pancreatitis. In this one, there is an acute inflammatory process, and then pancreatic tissue begins to bleed and become necrotic. They die off, and secondary bacterial infection results, which can also lead to formation of abscess. So clients with necrotizing pancreatitis, they can also recover completely. But sometimes they can have recurrent episodes of this thing that will now progress and worsen. Then we now see the person coming down with chronic pancreatitis. So I take it again. We have acute pancreatitis. Acute pancreatitis has two types, which can be self-limiting. They can heal on their own. And of the two types, we have the interstitial edematous pancreatitis, which is a situation whereby the pancreas become inflamed, swollen, and edematous due to this obstruction in the outflow of the pancreatic enzymes. So it just swells up, it inflames, and later on, the body manages it and it heals itself. The patient becomes okay with no complication. Then we have this necrotizing pancreatitis. So the pancreatic juice cannot flow through through its ducts, and as it cannot flow, it starts destroying the tissues. It starts destroying the tissues. Then the tissue will respond through an inflammatory process. There will be inflammation when there's destruction of tissue. As there's inflammation going on, the pancreatic tissue begin to bleed. They bleed out. And then that bleeding will cause a kind of, should I say, hematoma around there. Before you know it, the tissues will start dying. They will become necrosed. Then when there's stagnation of fluid, that is a good site for bacteria to breed. Then bacterial infection too. Maybe the patient had some kind of septicemia or bacteremia because of the manifestation and signs and symptoms that this whole thing would lead to. So that secondary bacterial infection will now cause an abscess to be formed in that medium, because that's like a good breeding ground for bacteria. We now have pockets of fluid, pores, and all those things. An abscess will form. And that is what happens in this necrotizing pancreatitis. It can now lead to recurrent episodes of pancreatitis, or it can continue. It can have periods of healing, and then it comes back again, being recurrent, and can lead to the chronic pancreatitis. Manifestations and complications. The onset of acute pancreatitis is very sudden. The patient develops continuous epigastric and abdominal pain. This pain commonly radiates to the back and is relieved somewhat by sitting up and leaning forward. The onset of pain often occurs after a fatty meal or excess alcohol consumption. Patients with acute pancreatitis may develop this hypovolemic shock due to vasodilation and fluid shift into the small bowel. So we have said that this whole thing, the signs and symptoms will just start suddenly, and the patient may notice that, oh, I finished eating a fatty meal. Let's use the example we like to use of egg. You fried your egg, you fried your yam and your fried plantain. You just finished eating it, and then the patient notices that, he's having this pain at the left side of the stomach that is radiating to the back. Then if he sits up, like you sit up in a sitting position and lean forward, kind of, the pain will now reduce. Another time this patient may notice it if you go to your friends, you have some party, you are going for a party and you consume high level of alcohol, and then after that you just notice, I'm having this left upper quadrant pain that is radiating to the back. Then you begin to see signs and symptoms. So with this acute pancreatitis, the patient may have hypovolemic shock, and this will happen due to vasodilation and fluid shift into the small bowel. Because of the inflammatory response, there will be increased capillary permeability, and this fluid will begin to leak out. It will begin to leak out, and the patient will have hypovolemic shock. Please, that's what I meant to say. Bleeding into the retroperitoneal space can occur because we know that the pancreas is a retroperitoneal organ. It's at that back portion. So when there's bleeding into the retroperitoneal space, we will now see that the accumulation of that blood at the back parts of the abdomen leads to the patient having this kind of ecchymosis or bruising mark at the flank area. So that ecchymosis or bruising mark at the flank area is what is called the Turner's sign. It can also bleed and come to the front area here near the umbilicus, and then we call that the Cullen's sign. A pancreatic pseudocyst, that is a collection. The pancreatic pseudocyst is a collection of blood. Blood, fluid, and then some pancreatic secretion in the abdomen, in the abdominal cavity. That one also develops. So the pancreatic pseudocyst will develop because of that collection of fluid, of blood that is bleeding from the pancreas, as well as what is it called? As well as secretions. Yes, pancreatic juices, secretions. Then now patients will have pancreatic pseudocyst. If this pseudocyst ruptures, if it bursts out, this collection of fluid, if it bursts away, we'll have peritonitis, inflammation of the peritoneal cavity. Another thing is the pancreatic abscess. The abscess we talked about is a collection of secretions and necrotic products within the pancreas, because those toxic enzymes that are being released will start auto-digesting the pancreas. Some of the pancreatic tissue will die. There will be bacteria will come to and try to eat them up, the white blood cells. They will also die in the process, and we begin to have necrosis. That leads to the formation of this abscess. So that collection of all these secretions and everything stays there. And that pancreatic abscess can be fatal. These complications usually occur 2 to 3 weeks after the onset of pancreatitis. Are we good? Are you jotting? Are you awake? Let's summarize what we have learned. We have talked about acute or chronic pancreatitis as an inflammation of the pancreas that is associated with escape of pancreatic enzymes into the surrounding tissues. We've also said that acute pancreatitis occurs suddenly, and then the attack can become recurrent, and then we have periods of resolutions. But the chronic pancreatitis is continuous inflammation and destruction of the pancreas. The pancreas also becomes replaced with scar tissue. So the precipitating factors for this problem include when the patient has trauma to the pancreas, or an alcoholic, or this biliary tract disease we talked about, where we see using obstruction of a of flow of bile juice by a gallstone. Sometimes viral or bacterial diseases can cause it. Hyperlipidemia, hypercalcemia, too much calcium in the serum, in the blood. Cholelithiasis, we talked about this. Hyperparathyroidism, because we know that in hyperparathyroidism there will be increased production of calcium. We also have ischemic vascular diseases. If there is a disease where the blood vessels become ischemic, there will be shut up or cut off of supply in blood to some parts of the body, and probably there's a stoppage. Oh Lord, what am I even saying? There is an obstruction or something that is hindering the flow of blood, or poor tissue perfusion to the pancreas. Then the pancreas begins to necrose. We also have peptic ulcer disease. These are the various precipitating factors. Assessment finding includes nausea and vomiting, weight loss. Because of the pain, these patients don't want to eat, because when they eat the high fatty food, they begin to have abdominal pain, so they can have malnutrition. There is decreased bowel sounds, elevated WBC level, elevated glucose. We see hyperglycemia, hyperbilirubinemia, hyperbilirubinemia. Alkaline phosphatase will be elevated, and then urinary amylase level. We are going to be seeing amylase in the urine. There's also going to be elevated serum lipase and amylase. We've talked about the Cullen sign and Turner sign, abdominal pain, including sudden onset of mid-epigastric pain. In the middle of the stomach, they have that pain, or in the left upper quadrant, and it will radiate to the back. We have said that the pain is aggravated by eating fatty meal, alcohol consumption, or even lying down in a recumbent position. The patient will have abdominal tenderness, distension, and guarding. The guarding will be there when there is peritonitis. Then for the central nervous system signs, you see restlessness and anxiety, as well as a low-grade fever. Interventions include administer parenteral nutrition. We need to give them TPN for their nutritional problem, and then give them supplemental vitamins and minerals to increase their calorie. An NG tube can be inserted if the patient is vomiting, because we said they have nausea and vomiting, or if they have biliary obstruction. So if you see an Nclex question, or you are solving your Q bank and you see interventions for a patient with pancreatitis, we can pass an NG tube. But we are to withhold food and fluids during the acute phase. So let's take note of that. And then IV fluid is very important to hydrate those patients and help in flushing out the toxins. When patients with pancreatitis are placed on MPO for a very long time, a nasojejunal tube is passed, and it is passed through the ligament of triads so that they can feed this patient. So we'll be doing a nasojejunal tube feeding for the client so that we can bypass the duodenum and all those things and all the issues that is going on there. These patients have so much pain, so we need to give them pain medication, and opioids are being prescribed. Then they have sometimes they have this peptic ulcer, and because of that, we give them the H2 receptor antagonist or proton pump inhibitors. We know the omeprazole, rabiprazole. Then the other one, we have the ranitidine, famotidine. So these ones will help to reduce the HCl production and prevent activation of those pancreatic enzymes. We also monitor patients' vital signs, because the vital signs can give us clues as to if this patient is having shock. If we begin to see hypotension, tachycardia, we know that they are entering hypovolemic shock. Then we check their level of consciousness, because we have to also observe for change in behavior and level of consciousness that may be related to alcohol withdrawal, hypoxia, or impending sepsis alongside shock. We tell them to avoid alcohol. So this is the avoid alcohol clients, not stopping, want to try to stop. They just have to stop it completely. Then they follow up with their HCP. Another important thing is that we have to notify the HCP if acute abdominal pain, jaundice, clay-colored stool, or dark-colored urine develops. So this is a reportable finding for our Nclex tip. We have to report the HCP. I hope we enjoyed this study session. I'll see you in the next one, where we talk about chronic pancreatitis. Thank you.